Kia ora anō koutou. I hope you had time for a coffee and a wee snack. I've just had one long black too many and a lovely cheese scone. The biggest news in town for health at the moment, other than COVID and public sector pay restraint, has to be the establishment of Health New Zealand and the Maori Health Authority. So we have devoted the entirety of this session until lunch to hearing from several people who are intimately connected to the establishment of our new health system. So I'm very pleased to introduce in the first instance Martin Hefford, who is the Acting Chief Executive of the Interim Health NZ. I hope I've got that right, Martin. Supported during the questions and discussion by our friend Dr. David Geller, who's described here as a clinical sector expert in the transition unit. We know him as a past president and loyal member of ASMS over many, many years. It's lovely to have you here, David. And Doctors Mataroria Linden and Curtis Walker. Curtis, of course, is also a current member of ASMS, who are both board members of Health NZ and the Māori Health Authority, will be joining us after Martin's presentation to be part of the discussion. No mai, haere mai, tēnā rā tātou katoa. I'll hand over to Martin now.
Give you an update on the health reforms and the Interim Health NZ and Interim Maori Health Authority establishment. I am the acting interim CEO for Health NZ, which is probably about as tenuous as you can be as a CEO, and keeping the seat warm and making some progress while the new boards go through their process of choosing permanent CEOs. And you obviously already know David, and David and I will do a bit of a double act. We have not rehearsed the double act, so we'll just play it by ear through this presentation. So we'll just give you a bit of an overview of where things are at and what's aimed to be achieved. Sorry, I'll just get that going. And where we're up to with the New Zealand Health Plan, the approach around localities, the charter, and have some discussions around the implications for the workforce, and then really looking forward to the question and answer, but it's usually more interesting for me. So the system shifts, and you've probably mostly seen this, but the key things that government have said they want to achieve through these reforms, first of all, is to reinforce and to meet treaty obligations and the requirements of the Treaty of Waitangi. We know that, for instance, Y2575, the recent finding by the Waitangi Tribunal, focused on primary care and found that that the Crown had not met treaty obligations in relation to primary care policy and implementation of that policy. And that was just the beginning of a series of claims around the health system. And we know that's evidenced by quite wide disparities in health outcomes, lower life expectancy for Māori, higher mortality rates at all ages, and evidence that Māori are treated differently in the system, but also not honouring the requirement to provide for rangatiratanga and for people to have their own choices and to provide their own services. So one of the key things that's intended out of the reforms is that we will have a health system that does meet treaty obligations. Second is around people being able to access comprehensive range of services in local communities with an emphasis on prevention and early intervention and helping people to stay well. And we'll talk about that a little bit more through the morning. Perhaps a critical point is that the current system has found it difficult to keep an even hand around investment in hospital and specialist services versus investment in resourcing for prevention, promotion, and early intervention. And the kind of structural, there are some structural elements in the reform that are intended to try and shift that balance. The equitable access to emergency and specialist care. We know that things vary by DHB currently and actually by PHO as well. We get some postcode lottery issues, and the access rates for things like knee replacements can vary 3 times between DHBs, and things like stroke pathways are implemented really well in some places and not in others. So having equitable access to these really important emergency and specialist care services is an important element of the future system. Digital services, and New Zealand was once a real international leader in the uptake of data and digital innovations. We were early to start to use electronic medical records, and early adopters of cell phones and FPOS technology. But we have more recently fallen behind where other countries have got to in use of digital services, and some of that is around the distributed decision making between 20 DHBs, 7 shared services agencies, and the Ministry of Health, and our kind of inability to make decisions to implement things once at scale across New Zealand, or to make sure that we use our leverage on the vendors to get interoperability and avoid locking in proprietary software. So big emphasis on data and digital in the new health system. And then finally, around the workforce, making sure that people are valued and feel well trained and supported for the future health system, that we've got the preconditions in place to have a workforce that will meet our needs, that we've got planning around. We should know how many obstetricians and gynecologists, for instance, that we need going over the next 20 years, and how many are currently coming through a pipeline, and what we need to do if those numbers that don't balance out, and what the distribution of that workforce needs to be to meet demand across New Zealand, as an example. So you may well have seen this already. This is a simplified version of the new system. The key things being the creation of Health New Zealand and the Maori Health Authority. Health New Zealand will be formed from the merger of 20 district health boards and their 7 shared service agencies, and will also be formed by incorporating a number of functions out of the Ministry of Health. Key ones being workforce training and the commissioning of workforce training and workforce planning and development, some of the data and digital planning and delivery functions for New Zealand, and some of the capital planning and arrangements for New Zealand, and then also the commissioning. So the Ministry of Health still has around a $3 billion commissioning budget, where they buy services directly, as well as giving DHBs money to buy services. So the commissioning will move from the ministry into Health New Zealand, and it will then be the employer of around 80,000 New Zealanders working in current DHBs, and be the contract agent for all of the other health service providers in the system, around about 1,600 contracts, as far as we can tell at the moment, and probably another 100,000 employees in that contracted sector. The Health NZ will bring the public health units together, and also the Health Promotion Agency, to create a national public health service that will focus on prevention, health protection, early intervention, and we will be reorganising care through communities into localities. The Maori Health Authority and the Maori Health Authority will have 4 main functions. One is that they will be providing contestable advice to the Minister and Government on health policy as it relates to Maori, so they will have a policy arm. Second is that they will be directly commissioning health services, predominantly kaupapa Maori services, so they will have a commissioning budget of their own. And thirdly, they will be co-commissioning with Health NZ, and that means they will be working with Health NZ to jointly agree key strategies, policies, plans, commissioning arrangements, etc., and national agreements that will apply across New Zealand. And that includes things like the New Zealand Health Plan. So the Maori Health Authority and Health NZ will work very closely together. And then fourthly, they will have a monitoring role in terms of how well is the system going, how's it working for Maori. The other key treaty partner is the iwi Māori Partnership Boards that will be strengthened and given more explicit formal roles in decision making, particularly around locality services and locality plans. The ministry will be streamlined and will be chief steward of the overall system, and we'll be able to focus on policy, regulation, system monitoring, and servicing government and advice to the minister. The New Zealand Health Plan, and David, I don't know, do you want to talk to this a bit? You've been working pretty closely with the New Zealand Health Plan.
Yeah, thanks, Martin. You can hear me okay out there? I can't see anybody. Cool, thank you very much. Well, yeah, the New Zealand Health Plan is a really enormous piece of work, actually, and it will be the result of, I suppose, the interaction between the enabling structures that the ministers announced in April this year in the Grand Hall of Parliament. Those structures are really there to allow, with the one employer, no district health board boundaries, and no IDFs. It does open up an enormous opportunity to work in different ways. And there's a couple of big cultural pieces that we'll come and talk about shortly, the Charter and the Consumer Voice Framework. And there is this sort of shift here, a quite significant shift in realizing that actually the outcomes of this reform will be best served by really lifting the voices of those closest to the delivery of service. That's yourselves, health workforce, your teams, together with the patients, the whānau and the communities that we actually serve and have some obligation, a significant obligation towards. And it'll be out of that dialogue that we will, a plan will emerge and the different models of care. The final, well, if in fact there will ever be a final version of the health plan, a more comprehensive version of the health plan owned by Health New Zealand and the Māori Health Authority will be delivered in 2024. And that will be signalled through a range of different strategies, government policy statements. It will span all services from locality-based services and communities all the way through to high-end hospital services. There is a precursor to that, the Interim Health Plan, that has got a number of really big work streams associated with it, that the Transition Unit and soon Health New Zealand will be working on to deliver to the boards by September next year. And that precursor of the final version of the health plan will really be a leg up. It's a bit, if you think about it as a relay race in a funny sort of a way, it will be handing on the baton for Health New Zealand and the Māori Health Authority to carry on with the definitive work. The interim health plan has a number of elements to it that's on the slide at the moment. It will incorporate into all aspects of the work the principles of Te Tiriti o Waitangi And it's really interesting and really important to explain to you that in the run-up to the announcement of the makeup of the boards, in particular the Maori Health Authority board, all of the streams of work in the transition unit were run past a group led by Sir Mason Jury, and and informed by their input, and together with the charter and the plan, I was part of a group that took a lot of that work forward, and it was a fabulous interaction, and really about how do we actually do this in very practical terms. And so the interim health plan will really set the scene for the final version. Currently, there are expert groups or some people informing the work of discovery, really, around what the interim plan might look like in the community setting, certainly between the community and local hospitals, across hospitals, hospital networks, in specific areas like mental health and addictions, first 1,000 days, aging well, and other pieces of work too that you can see up on the slide. One I'm particularly thrilled about is the carbon neutral work, which is now part of the interim health plan. And there's a lot of work going on, obviously, around the workforce capital and data and digital space. And that this work will continue until September next year, and then be worked into the ongoing work by both organisations to develop the final plan. What is really important here is that this work will be as good as the engagement that we have with people like yourselves. And certainly up to now, we're really grateful to Sarah and the ASMS and for giving up the first hour of the pre-meets and for those JCC meetings to have conversations with members of the ASMS from all over the country, actually. And they've been incredibly helpful to us to inform us about the issues that you're facing now, some of the opportunities that you see with respect to the reform, and particularly with the plan, and the issues that particularly that relate to more rural and provincial organisations, and the issues that they're facing in providing services close to home. But we're also really interested in and have been really interested in the opportunities that you see for this reform to assist you in doing the work that you actually do. The group within the transition unit, soon to move into Health New Zealand, that are working on the plan have been meeting with a huge group of people, and engaging pretty thoroughly as best we can, learning as much as we can across the spectrum, across the whole health sector, from community-based work to high-end hospital work, about the things that are going really well and opportunities to actually leverage off those things, to recognize the workarounds that so many of you are doing to provide really good services, and to learn from those so we can actually find ways to formalize those in the final plan. Ultimately, what we hope to see is that we will see an integration of services into networks where all of us will be connected to within our localities, within local hospitals, within regional and within regions, and nationally too, so that actually there will be opportunities for a greater degree of support, a greater degree of opportunity to network resource, and to use our expertise in new and different ways. I'll stop there and hand back to Martha. Thank you, Martha.
Thanks, David, and thanks for your advocacy on all sorts of aspects of the plan, but also on the carbon neutral and getting that included in there. It's been, I think, a great step forward. I just talked briefly about the locality approach because it's been in the media, and it's been part of what the minister's announced. The thinking is that for many people and for communities as a whole, health services are only a small part of what determines health outcomes, and particularly what determines health inequalities. And if we want to make a difference to health outcomes, then we need to go broader than simply delivering health services. We need to influence what people eat and what people drink, and how active they are, and their health-related behaviours, smoking and sexual behaviours and gambling, and how well they deal with anxiety and life events and so on. And we need to deal with some of the socioeconomic influences on people, and things like access to good jobs and employment and housing and so on. And we recognise that health can't do that alone. It's got to be part of a solution. It can't be. It's not able to tackle housing or education or poverty or those things, and even health-related behaviours. It's not simply a matter of providing education. We know that behaviours are deeply rooted in things like active transport and access to green spaces and the urban environment, and marginalised individuals are more likely to smoke. So this calls out some of the features that are important in implementing a population health improvement approach based on place and on locality and local communities. And it starts with partnership with Maori, and the iwi Maori partnership boards are intended to be a way of providing a mechanism for mana whenua to come together and to represent and to identify the needs of local whānau and to prioritise those and to give input to commissioners to say, this is what we need from you when you're purchasing health services. And then the partnerships with local communities and with local government, etc., to work on the social determinants of health. The joining up of healthcare and health and social care, so that when people have complex needs that go across health and social services, we've got the ability to provide interdisciplinary services that mean they don't get handed off from one to another, but can get a coherent and coordinated response. We're a long way from that at the moment. We're challenged currently even to join up health services, let alone health and social care in most places. Different models of care, recognising, we don't have enough doctors, we don't have enough GPs, and we need to make sure that we've got teams around people that can deal with some of the tasks that otherwise land on medical staff's plate, and that we've got the right levels of services. As an example, we would be looking for, and I'll come back to this in a bit more detail, comprehensive primary care teams rather than GP and nurse type primary care teams. Data and digital we've talked about already, and one of the key things there is about data sharing and interoperability between providers within a locality. And we know that nearly all of our providers are using electronic data. It's just they're in silos. We have trouble joining them up, with some exceptions, Health One being one of them. And then the community engagement, the locality plans need to reflect the needs and aspirations of communities, including the vulnerable populations that aren't going to come to a town hall meeting or make a submission. We need to find ways of getting their voices in quickly. This slide is trying to capture some of that. Part of the vision we're seeing is that in a locality where we'll have comprehensive primary care teams that might have different flavours in different areas for different populations. You might have rural comprehensive care teams that recognise the realities of rural life and have a broader scope of practice in those areas, including, hospital generalist, rural hospital generalist qualifications. And in terms of Pacific comprehensive care, a comprehensive care team for Pacific people in primary care would need to recognise high rates of diabetes and might include, retinal screening, podiatry, and diabetes nurse specialists and endocrinology, and some of the making sure we're giving really optimal treatment to manage that diabetes, and the kind of dietetics and the early intervention services that might avoid and reduce the prevalence of diabetes. And then, you may not be able to see this well, but the thinking about broader than the primary care teams, or want to join up, for instance, maternity and well child services, so that the midwives and well child nurses and GP practice nurses and GPs actually work together as a team around a woman and baby, rather than being currently, as they currently are, siloed, and can connect up with social services and hospital and specialist services as well. I'll keep moving. I'm conscious of time, and I'll ping back to David to take us through the charter, which is again a hugely important part of the health reforms. Goes far beyond structure and more to the heart of the matter.
Thanks, Martin. The announcement that the ministers made in Parliament in April this year, a lot of attention was placed on the structures that were announced, and I think they all took us a bit by surprise. You know, instead of 12 or 8 or 4 DHBs, there was the creation of One Employer Health New Zealand, and the stunning announcement around the Maori Health Authority to actually have the resources and the mandate to develop kaupapa Maori services to make a material impact on outcomes for Māori. I think all of us were taken by surprise. The ministers at the time spoke about these structures as being enabling structures, and with one employer, essentially no DHB boundaries and no IDFs. There is an opportunity for the workforce to collaborate in ways that we haven't been able to do in the past because of the structural barriers of the previous system and the way it was organized, to really make the best use of the enormous resource that we actually have. To aid that and to assist with that, the idea of a health charter came about. And the idea of a health charter came about to actually really, it's really a conversation about what is this sort of the things that we would like to do to lift the voice of our healthcare workforce, to actually, to have them actively engaged, for them to be actually valued in ways that perhaps we haven't been valued in the past, for us and our individual contributions, those of our teams, to be valued for the specific things that we actually do, and how those contributions contribute to the outcomes of the whole reform. What is that kind of culture that allows us to work in really productive teams, to actually sort of support colleagues in other parts of the country? What is that culture that might sort of encourage us, you know, to work on a number of different sites, should that be our choice, and should that suit us? And so the idea of a charter came about out of all of those hopes and aspirations. And there is a charter team that is led by Andrew Norton, and I'm part of that team, and Anna Marie Ruhe, and Emma Bailey. And we've met a number of you, of course, already in the JCCs, and we're continuing to meet with many groups across the New Zealand health workforce, particularly the CTU unions and the Apex unions. And we're hearing some extraordinary stories about what opportunity those people see that this charter might deliver for them, for their voices to be heard, and what difference that might make to workplace relationships and their ability to do their jobs in different and better ways. The charter itself will bind all of the health workforce together in a common purpose. That's the term that the phrase I've been using quite a lot. And when I say all, it includes the board members, the chief executives, the managers, the clinical staff, the non-clinical staff. That's of the current DHBs, that's the 80,000, plus those we contract with. So it is a really extraordinary opportunity, and together, this piece of work, together with the consumer patient whānau voice framework that the Health Quality and Safety Commission are working on, which is a framework to assist all of us to engage with patients and whānau and communities, and to learn from really good examples that are carrying on that we've got in New Zealand now, to actually ensure that that's being done really, really well, and to help us do that really well. These two pieces of work are really kind of magic, actually, because it's out of these two pieces of work that I think possibilities will arise to do things quite differently,
David,
to improve our lives. Yeah.
David, I'm very sorry to interrupt, but we have got some fantastic questions here for you and Martin, and I'm conscious that Curtis and Mataroria are due to join us at 12:15. So would it be all right if I put some questions to you and Martin?
Oh, yes, definitely. I'm sorry to have
no apology required.
Yeah. No, okay, all right.
And we can take the slide away if that's.
Yeah, we're all
useful.
good. We're all good. We can see you both.
Good.
Thank you.
All right.
So
we've
got some fantastic questions. It's just harder to nudge you when it's virtual.
No,
so
good on you.
So Amanda Tristram from Cape Coast asks, can you update us with current progress on system shift number 5, making healthcare workers feel valued? How will this be objectively measured?
Well, that's a yeah. You go, Martin.
No, you go.
That's a hard.
You sound like you knew what.
Well, I don't know the answer to that actually, Amanda, and I think that we would be very interested in talking with the ASMS about that. It's a very interesting thing because we are discussing with a number of different unions the very issue about how do we know we're making progress? Why is this reform going to be different from other reforms? Will it just slip back to the same old, you know? What are the things that we need to watch out for? So, you know, I think that we did at one point, and it was with the Apex unions actually, that we were discussing the idea of having a workshop with them around some of these particular issues, around the shifts, but also around the impact of the charter on workplaces. How will we know? And so we have some ideas, you know, around the things, the material things that we can do. Some of those are quite nascent, you know, to tell you the truth. But there is a, you know, but there is a need to actually have objective ways to actually measure those things. I might just raise one. I know that we're meeting with Joe Sinclair and a few other people from the SMO leads who have got well-being appointments and some of the DHBs, and we're going to be really interested and to have that conversation with them. And I know that's a really big issue. We've had some meetings with the occupational health group, actually, you know, around, you know, what they're suggesting around having a national occupational health service for all of the workforce. So, I mean, there are conversations going on, and, you know, this is a work in progress, I have to say. And so, you know, please, we would be really keen to develop these things together. That would be my answer to that.
Martin, I don't know if you have a comment on that, but here's one specifically for you. It comes from Anna Dawson, who's a specialist dentist at Green Lane. She asks, how does Health NZ envisage integration of mostly private primary care services, such as adult dentistry, optometry, physiotherapy, into primary medical care will happen, and when cost is a barrier to so many New Zealanders?
Great question. The only way we can, I think, effectively start integrating those private services is, the only mechanism we're going to get is if we can get some of them to be publicly funded, even if it's just around people with lower incomes or deprivation. Now, that's a matter for government, of course, because governments will decide what the priorities are for funding. But we do know that once you've got contractual levers, we can have conversations and set requirements around how people operate and what information they share and how they work in a way that you can't do when they're entirely private. There is some work that can be done also with ACC. So if you think about things like physiotherapy, there are discussions with ACC about how we could align commissioning across Health New Zealand and ACC in a way that was a bit more difficult for them when they were dealing with 20 DHBs. My comment on the workforce one was just to say, look, I do think that measurement is important on that. I would really, and I was thinking that one of the, there are tools that can be used to give a bit of a heat map. We know that in some places in New Zealand, people do feel really valued by, the team they work in, and then the leadership structure they work within, and in others they don't. And we should be able to make that explicit if we get the right instruments and feedback loops going on with people.
We would say that the current system measures the things it finds most important, and we consider that is currently at the detriment of the healthcare workforce as a whole. We certainly have lots to suggest. Look, we asked Minister Henare this morning the same question, but we'd like to know about your commitment to continue formal engagement with workforce and with health unions under the new structures.
Look, I can report that our second Interim Health New Zealand board meeting, the chair proposed and got full endorsement from the others that one of their priorities was working in partnership with all of the relevant health unions and health workforce, and that a partnership approach was going to be required, and everybody supported that, which I thought was a really good start.
It is a good start. We have formal engagement mechanisms with every DHB currently, so it is a priority for us to talk to you quite soon, Martin, about what that looks like, and I would expect national formal engagement from the beginning of next year, and then regional engagement from July onwards would be our preference, so we'll need to set up a call about that. I realise a gap in our conference planning is we probably should have given you guys access to Slido as well, so you could see all the questions stacking up. I don't think we're going to get through all of them, so we will mail you the ones we don't get across. But the next one, cab off the rank, is from John Chambers. He's an ED specialist at Dunedin, and you may know he's also a board member. Commissioning and contracting hundreds of contracts with yet to be set up providers, all within a few months, in the middle of a pandemic. Perhaps it should all be delayed for a year or so. I think I know what your answer is going to be, but there it is for you to respond.
Sure. And it's a good one in terms of why would you do a health reform in the middle of a pandemic? And that question's been raised a few times, and it's a fair one. I think the couple of points I'd make. First of all, the way that the reforms are being done is aiming to try and minimise the impact, particularly on frontline services, both people working in hospitals and in communities and in contracted providers. And that's being done by seamless transfer of employment arrangements, so that everybody gets transferred without having to do anything, with all of their balances, entitlements and so on preserved. And secondly, by transferring all the contracts as well. So the contracts will transfer over from existing DHB contracts to Health NZ without anybody having to do anything in particular. It'll be done through legislation to try and minimise that frontline impact. And then we can start to put some more supportive structures around things nationally to start moving on those key shifts over time.
Thank you. I've got a couple that are sort of similar, so I'm going to put you two, so you're going to have to stick your listening ears on. I completely agree, this is from Siobhan Cross, I completely agree that long-term health prevention is the main determinant of health, but the outputs of this are over 30 years. Can you reassure us it will not be at the expense of services of those who have illnesses now? And then attached to that, Aaron George comments, the principles are all great, but what additional resources are being pledged towards all of this to ensure that this will not be a rearranging of the deck chairs? And I think that is a very common, widely held anxiety about what the health reforms might really mean or not mean to people at the front lines of healthcare. So, we don't think that the predicted savings up front are going to be sufficient to fund a currently desperately underfunded health system, particularly the secondary and tertiary care that most of our members confront on a day-by-day basis.
Yeah, I think it is a common anxiety. Thank you. My comment would be that the government have I think, been quite good in terms of not trying to, not trying to get any savings out of consolidation. They've not said, oh, okay, you're squeezing together 20, DHB CEOs, and therefore you should be able to make some savings out of that. They've said, no, we understand that the health sector is pressured, and that any efficiencies that come out of, streamlining things just get ploughed straight back into frontline services. The other thing that is related is this idea of a bit more transparency and more longer term funding pathways for health. And that reflects the government policy statement, which David talked about earlier, is in the Pai Ora Bill, and it will be a requirement that the Minister of Health sets out a government policy statement, and that will include statements about the resources that will be available over the subsequent 3-year period for health services. So that gives us the ability to plan in advance, which is useful, but also that will be based on analysis of the actual, the known increases in demand and population, and, the known pressures around, staffing and wage settlements and so on. So that the opportunity that goes is that when we do our health plan, we know what budget there is and what resources there are. And also there's a transparent trade-off for the government. They can, they need to decide how much resource they want to put into health, and they need to do that understanding the consequences of not putting as much resources as are required to meet demand.
Thank you. Look, I've got a question. I understand that Curtis and Mataroria are now with us, so I'm going to give one final question to you before we hand across to them. This is from Dearly Flower, who is an ONG specialist working at Auckland City Hospital. She asks, will the hospital boundaries continue to exist? Specifically, can people choose where they get their care, assuming the service they need is available at the hospital they choose? This has implications for resource planning when patients choose a different location to their current domicile.
Yeah, so the kind of inter-district flows construct will disappear, and instead we'll be aiming over time to move to a more planned system, which can take into account the changes in people's preferences as they shift to where they want to get services. It might also mean that rather than trying to do everything everywhere, you might want to create centres of excellence in some services. Now that's something that will only happen when people say it's the right thing to do. But if it is the right thing to do, it won't be constrained by district boundaries. So we may want to create those centres of excellence for people. And alternatively, we might also want to create networks, specialist networks that run across sites that aren't linked to a particular hospital, but run across hospitals. So I think we can think a little bit more broader than we've been able to under the DHB framework.
I think a final comment for you both before we introduce our next two guests would be that we desperately need a health system that is led by clinical decision making, that puts not just the patients in the centre, but our healthcare workforce. And I think when we talk recruitment and retention, which are two other priorities that are dear to our hearts, we need to do the retention bit first and look after the people who are already here in the system, and then also look to the recruitment part. But I do look forward to having some further discussions with you, Martin, and I really want to thank you too, David, and your team from the Transition Unit for all the time you've spent talking to us through our JCCs and this morning. I believe we now have Curtis and Mataroria with us. Tēnā kōrua, thank you for finding the time to join us this afternoon now. I'm not sure how much of the conversation you've heard, but we'd like to give you the opportunity to have a brief chat with us about your work on the boards, and then we have a number of questions stacked up that we might want to throw at you as well before we break for lunch. I also see it's just popped up on my screen that Judith Collins is no longer the leader of the National Party, so that must be a great shock to us all. Anyway, tēnā rā kōrua, and nau mai, haere mai ki Toimata Hauora.
Tēnā rau e ki te tae mai nei ki te tautoko hia te hui a te Toimata Hauora a Aotearoa, nā reira tēnei te mihi ki ngā rata rangatahi, ngā rata taumata aro mai me ngā rata rangatahi, kua hui mai nei e tēnei ai hei nei reira, tēnā tātou. Tēnā koe e mataroria, ko koe te tai hoa nunui, mā runga i te poari mana hauora, nā reira. Tēnei te mihi ki a koe, koutou ko Martin Hefford, nā reira, huri ki te whare, tēnā tātou. Kia ora, Sarah, and I see my good colleague from Mid-Central DHB, Natalie de Vries, sitting at the table there as well. So thanks for the opportunity. I'm not quite sure how you wanted to run this. I'm happy to pick up any questions or just sit into the background. And just because I'm trying to get my ahua switched from, if you see I'm sitting in my clinic room, I've just had to sort of defer a patient. Sort of say, can you come back at 1? Because I've got to do a very important hui about the Health New Zealand. So very much still at the front line, which I think is a strength to have a frontline clinical perspective on these boards. So I certainly bringing that, as well as long serving ASMS member and supporter of a strong sustainable health workforce. So I'll just maybe open with those comments, because I do see so many opportunities in these reforms for our health system. I'm sure Martin's spoken to that already. The massive opportunities that exists with the reforms, and we've got to seize those, and I'm very pleased to be part of that. So huri noa, I'll just hand over to Mataroria, but happy to really just to listen and answer any questions.
Tēnā rā koutou katoa I raro I ngā taumahatanga o te wā, ka tuku mihi atu tēnei kia koutou, e te Toimata Hauora, koutou katoa ngā raurangatira mā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Kia koe hoki Curtis, te tuakana, tēnā koe, mō tō mahi I rungi te poari hoki. Ko Mataroria tōku ingoa, hiori o hau no Ngāti Hine, Ngāti Whātua, me Waikato, nō reira tēnā koutou. Kia ora everyone, my name's Mataroria, and I'm a member of the Maori Health Authority. And I just want to start with my mihi, which acknowledge the challenging times that we're in. And I mihi to the ASMS Toimata Hauora around the mahi that you're doing during these challenging times and your membership, our frontline health professionals. It's a privilege for me to join on behalf of the Maori Health Authority and to be recently appointed. It's a privilege he honore nui tēnei, in order for me to do the best I can on the board around realising the aspirations of Hauora Māori and making a better health system for Aotearoa, for our patients, for our whānau, for our communities, and for our health workforce. So I just want to start there around both mihi, acknowledging the challenges, but also the privilege I feel in serving Aotearoa as a member of the board of the Maori Health Authority. And in starting and talking about the Maori Health Authority, I might just pick up on mihiing to those who have come before me, the pioneers of Hauora Māori, who 30 years ago had the aspiration and the tono or the ask, the request for a Māori Health Authority. And this has come to fruition over this past month. And so I mihi to them firstly for setting that path or that tuapapa, the foundation for the Māori Health Authority, and for me having this honore, this privilege to be a member of the board. And I just acknowledge our co-chairs, Sharon Shea and Tipa Mahuta, as co-chairs, and my fellow board members who span general practice, public health, Māori health providers, and health governance as well. And I just want to share a few kōrero about the Māori Health Authority and some of its functions and its important role within the health reforms and the future health system. And I want to start by talking about the current reality of COVID. And thinking back to a year ago, ASMS, I believe, was in Wellington. We were COVID-free with no community transmission. It was probably a large gathering, and the vaccination rollout was just being planned for Aotearoa. And if we fast forward to the new reality now, 3 months of lockdown in Auckland and parts of Aotearoa, the impact on the health workforce and on planned care and hospital services, but particularly the inequities that we're seeing for Maori and Pacific communities. Maori now make up the largest numbers of COVID cases and the highest numbers of COVID cases each day as well. Second to Pacifica is second. So thinking about the inequities that are currently faced by Maori, but also the inequity within the vaccine numbers as well, where Maori are 20% lower than non-Maori, and even worse in parts of rural New Zealand and among rangatahi or young people who are Maori as well. So I start there when I think about how could it be different with the Maori Health Authority from a COVID perspective. And some of the functions of the Maori Health Authority, and I'll just highlight a few, is around equity and working in Te Tiriti partnership. And so I see a future health system in which Maori and the Maori Health Authority will be at the forefront, including strengthening Maori leadership, prioritising Maori health and national planning and strategies, including the New Zealand Health Plan, but also in terms of our future COVID response. Secondly is around commissioning kaupapa Māori services and other services targeted at Māori communities. And I want to see the innovation that we've learnt through COVID, and particularly among our Māori health providers, translate and carry forward into the new health system, including how we've seen outreach services for testing, vaccination down to the community level and door knocking that's happening as we speak around trying to increase Māori vaccination uptake. And the massive collaboration that we've seen happen through the health sector in response to COVID. The third function is around supporting innovation in kaupapa Māori services. And we've seen Māori providers do a big job around trying to increase vaccination uptake among Māori communities. And part of that is around the wraparound services that are happening, particularly for whānau who need to self-isolate and are positive with COVID, and the health and social wraparound that's currently happening that we need to see more of in the future health system. Just a couple of other key functions around the Māori Health Authority is around strengthening data and digital, including better telehealth access to increase access to care, ethnicity data, and also the sharing of health information that needs to happen in a timely way, particularly during a pandemic. And we've seen some challenges around sharing of data for community providers. So the Māori Health Authority will be taking a role in data governance and Māori data sovereignty. Just a couple other functions is around localities and iwi Māori partnership boards. And Martin may have spoken to the locality model around enhanced primary care and iwi Māori partnership boards being a new part of the future health system, particularly around elevating the whānau voice and around identifying local community priorities within locality plans and agreeing to those. Three other functions is around supporting the workforce and provider development, which I'll speak to more as a key interest of mine, monitoring performance of the health system, and also embedding equity in the planning and management of hospital specialist services. So the Māori Health Authority will be working in partnership with Health NZ around the planning of those services as well. And I'll just finish off with some of my own personal interest areas based on my work. Firstly, as a senior lecturer in medical education, where my PhD was focused on motivation and burnout among medical students. So I have a keen interest in the workforce pipeline, having come through it myself as a MAPAS student, Māori and Pacifica, to particularly increase the number of Māori and Pacifica students coming through that pipeline and into specialist training. We now have record numbers of Māori graduates and seeing the pathway with ASMS into medical specialty careers is something that's of interest to me, along with medical workforce wellbeing. The second interest is in terms of public health and prevention. And my work and my background is in public health. So along with the establishment of the Public Health Agency as a new entity, I'm really focusing on cross-sector collaboration around action on those social determinants of health. So from a prevention perspective, that's important to the Māori Health Authority. Enhance primary care within the locality so that we can see more happening in primary care, more accessible services rather than turning up at hospital, and more services being provided in primary care to take the pressure off hospital services where it's safe and appropriate to do so. Specialist and hospital services is an interest for the Māori Health Authority and for me personally, having worked as a medical officer at Middlemore, worked in private, and now as the chair of the hospital committee for Whangarei Hospital, and seeing the pressures of planned care and the variation across services and accessing planned care different surgical thresholds, planned care thresholds across DHBs, which I think we need to get on top of for greater consistency of care across the country. Kaupapa Māori models of health, and that's something that'll be through the Māori Health Authority, Te Whare Tapawha and Māori models of health that we can increase within the health system. And just lastly, data and digital. And in my role as clinical director at 10 Health, which is a primary care service, digitally led to access care through our app, but also in our clinics, the opportunity in the future health system around increasing access for whānau to healthcare through telehealth. We've seen that through COVID, increased health information for whānau to better self-manage, but also for health professionals as well, around having the flexibility of telehealth to work in different ways online or in the clinic where possible, within the hospital, as well as greater access to health information for our patients, where we see these silos that are happening between primary care and general practice that don't necessarily have access to hospital information and vice versa. So how can we increase the connectivity across the health system through a new national telehealth data and digital platforms that I hope to see through the health system reforms as well. So I prepared a couple of comments to make as opening remarks, but just want to mihi to you for the invite today, and I look forward to our kōrero and Q&A together. Kia ora tātou.
Thank you, and kia ora, Mataroria and Curtis. My name's Julian Weiss. I'm the president of ASMS. I have a question with a slightly long preamble, so forgive me, and it's actually a question more around board process and governance for you, but I think one that is really quite key to many of our members. So I think the Health Charter acknowledges the fact that a critical element for success of this work, of this project, is the establishment of strong and trusting relationships, mostly and most importantly between service users, between iwi, Maori, and the commissioners and providers of these services. But I would also say that a similar strong and trusting relationship is needed between clinical staff and actually service managers and senior leadership teams. You'll no doubt be aware that ASMS has repeatedly signalled the importance of not just distributive clinical leadership, but for actually effective mechanisms for constructive collaboration with senior clinicians beyond those with formal roles. And I say that for dental and medical staff, but also nurses and allied health professionals. Unfortunately, my observation from conversation with many members is that this is not always the case within DHBs, and it is certainly a culture of collaboration, a culture of engagement and conversation, shall we say, is not something that is, I think, routinely hardwired into DHB DNA. And many senior doctors and dentists actually report feeling at least shut out, if not actually something that is tantamount to gaslighting from their immediate managers or those slightly higher up the food chain within their hospitals. And I'm actually really quite worried that there is a risk that by simply transplanting the current culture into the new organisation, there will still be the risk of the same cultural deficiency. And I think without workforce confidence that this can change, the likelihood of maximal success is going to be limited. So my question, there is a question, thank you for being patient, is from a board perspective, what safeguards over and above the Health Charter do the boards, both boards, feel have to be in place to support those in management and senior leadership roles who are moving from a DHB culture, shall we say, to the new workplaces? So to support them not to simply revert back to reiterating the current culture, the current modus operandi. What do the boards have in mind to ensure that we can actually move forward with meaningful and appropriate and actually helpful conversations, helpful engagement to make this whole process work, which is what we want, our members want, as much as you guys want. Thank you.
Kia ora, Julian. I'm happy to take that one on first and then hand over to my colleague, Mataroria. Well, firstly, I'll just, in response to your preamble, yes, agree entirely with it. And also agree that the potential risks are that the system does not change across all of the intended aspects of the reform. or doesn't, and it really needs to change across all intended aspects of the reform, both in digital and data, reorganisation of hospitals into networks, localities to provide community services in Australia. And one of the key shifts of the reform is that strong, enabled, engaged, sustainable workforce. And we have clearly set that at our board. That informs any of the discussions we're having as we consider the upcoming New Zealand Health Plan in conjunction with the board. I've repeatedly said it's not the 8 people around Health New Zealand board or 8 people around the Mana Haora Maori, the Maori Health Authority. It's not the 16 people around those board tables who count, it's the 80,000 people who are currently employed by DHBs or in DHBs, and the existing leadership and expertise that we have to get on board with these reforms. And so everything we're doing at the board level is really trying to signal that culture change, a move from a transactional type relationship to more relational type relationships, for want of a better term. And I've been pleasantly surprised in conversations with my colleagues and union colleagues, etc., about the change in tone and the signals that should be sending to the workforce that really is time for a reboot and a reset of what have become really fractious relationships and ultimately unsustainable relationships over the last 10, 20 years. So at the board level, it is a key strategic priority to engage the workforce in all of the aspects and in all of the ways that you might imagine that means, from both sort of the industrial, for want of a better term, training, development and pipeline, and support and clinical leadership and clinical networks and maximising that across the country. I'm also aware I've only got about 1% cell phone, so if I disappear, it's not because I don't love you all.
Kia ora, and tautoko Curtis's kōrero, and just to add a couple more points to it from a Māori Health Authority board perspective, in my own individual capacity and what I've seen so far as a board where we've been established over the last couple of months, is particularly about not just being the charter or not just being a structural change. It does need to be a cultural change that happens within health as well. And so from a board perspective, we're very much looking at not business as usual in terms of how we operate, in terms of how we appoint our management or leadership structures. And we're currently, in terms of the initial stages of setting up the Māori Health Authority, looking at exactly what are the types of leadership roles that are needed within the Māori Health Authority, rather than following traditional, perhaps DHB structural management roles, leadership roles, to actually try and rethink how we might do that differently. So I just wanted to make that point as the first thing as a board. Secondly is around the importance of clinical leadership and Māori clinical leadership, that we do see the need to elevate within how we work within the Māori Health Authority, including Māori medical specialists and other professions being a critical part of the knowledge and information and specialty expertise that we need around the planning that we do. So part of the Māori Health Authority is around planning, strategy, commissioning in partnership with Health NZ. So definitely looking at how we structure that around the people that we have within the Māori Health Authority in those roles is another critical step that the board wants to see get right. And we're currently recruiting our CE and going through that process at the moment. Curtis is going to pop back. And just lastly, also around the importance of the Charter, but also around the importance of engagement with Māori communities, iwi Māori partnership boards being another part of that, the focus on te tiriti and equity within health, kaupapa Māori approaches, anti-racism approaches within the health system is another area that the Māori Health Authority will bring to the table as well, to try and influence some of the culture change that's needed within the health system.
Thank you for that. If I could just come back very, very quickly on that. I mean, I think it's good to hear from both of you about your thoughts. Can you hear me? I guess the only comment I would make is that obviously you can tell from my voice that I'm not a Kiwi by birth. My perception is the notions of working in partnership and collaboration are perhaps more what you say intrinsic to Maori approach to collective activity than maybe, should we say, a more European approach, which may be more hierarchical and didactic. I've no doubt that current organisations don't wish to have a command and control model, but it has happened, and I would therefore suggest that we need to perhaps understand how those things have come about and how we can prevent them happening, not necessarily at the top tier with boards and senior leadership team per se, but as things trickle down through the different tiers of managers, which I think is often where those blocks and those concerns of clinicians being ignored happen. So I'm grateful for your comments and look forward to this being something we can make happen. Thank you.
Okay, I've got an actual question for you, Mataroria, and so good luck. This is from Carol Chan, who's a paediatrician at Tairāwhiti, and she asks, how will we ensure that all localities have equitable access to tertiary services? Currently, we don't have it across 20 DHBs, and with considerably more localities, we need to ensure it doesn't become an additional barrier to access and to resourcing.
Kia ora and mihi to Carol from our days. I think it was at Middlemore, actually, back in the day. So thank you, Carol, for your partai and for your work with tamariki. And I'll start with this question around localities and then also pass it over to Curtis. So currently, as Martin had also spoken to around the locality model and what the next steps is around prototyping the locality model in order to be able to look at what are the key ingredients or the key needs that need to happen to make the locality model work across Aotearoa. So we're not rolling it out all at once because we need to look at, okay, what is a locality? What is the size of the locality? What is the geography? And what is the populations? What are the mix of services that are going to be needed? How are they going to link together or as part of a network or integrate services across a care pathway, for example? And in the locality model, you would have seen child health or mama pipi tamariki, mental health complex care. So that's another part of it, including IT enablers to be able to increase data sharing across the locality too. Funding models that need to also work effectively to be able to make a locality be effective. And part of the important step as well is around the establishment of iwi Māori partnership boards across localities to be able to both bring the whānau voice, local priorities into the locality plans as well. So what I just wanted to highlight was that we do need to prototype different localities, which will start in the next year, to make sure that once they're across Aotearoa, that we're able to look at what are the key ingredients for success for a locality model, including, like Carol said, around the issues of making sure that there's good access and that there's good consistency across the country. So we need to work through that still, evaluate it before rolling it out across all of Aotearoa.
I'm not sure if Curtis is available to comment at this minute. No, he is.
I'm back.
You are there, Curtis.
Yeah, I'm back, and I've found a cell phone charger for one of my nursing colleagues just down the corridor, so now I won't have the excuse of being able to drop out.
Did you catch the question?
I did. Yeah. This was from one of our paediatric colleagues about ensuring that localities will have equitable access to secondary and tertiary services around the country. I'd actually extend that question to also make sure that there's accessible emergency services. One of the key goals of one of the key system shifts of the reform is to ensure that we have accessible emergency and specialist care for all communities when needed. I think one of the things which helps us with the reforms is that we are looking to no longer be bound by geographical constraints. So just, your secondary or your tertiary service traditionally has or hasn't been provided in DHB X to a greater or lesser, and in many cases, inequitable degrees, hence the postcode comments. I think what the reforms afford us is an opportunity through hospital networks, which make clinical sense, to put our clinical resources where they're needed, but most importantly, where they can be accessed in a logical sense, as I say, not constrained by geographic boundaries. So I think, as Matarori has said, there's obviously a lot of devil in the detail to be worked through about where and how that sits. But I think we have a much better opportunity to move the pieces around the chessboard to get a much stronger accessibility for all of our secondary and tertiary services for all of our localities. Localities are still being prototyped up, and there's a lot of obviously moving business as current. Our first priority, to be honest, is actually to set Health New Zealand up so that it can receive the current system and ensure a smooth, seamless transition, while also preparing for the future state and driving the innovations that we need. So there's kind of, a few balls in the air, but it is key that our localities will have access to appropriate hospital networks, secondary and tertiary services, and equity is in every single conversation that we're having, and we are constantly reminding ourselves of that at every board conversation.
Thank you both for your comments. I'm conscious that we're nearly at lunch, so but I just want to wrap up with a final kind of comment and question. I was really heartened by your desire to shift from what you describe as transactional to relational cultures across our health system. I don't think you'll find any disagreement from us about that. But I am really concerned that what we consider to be the ongoing failure to fund health appropriately, how that plays out is that we have, I think, quite a few adversarial relationships in hospitals, many of which arise from the fact that people are trying to make something out of not much, and that typically sets clinicians in opposition to managers who are given a priority of managing a budget, and a budget that is not sufficient to the many tasks we currently face. And I'm also mindful of your desire not to move a business as usual approach, particularly in the setting up of the Māori Health Authority, just simply taking what we see in DHBs and moving it across, same dog, new collar sort of situation. So I'd really be interested to know how we're going to affect that change, given what the current health system looks like, both in terms of staffing, structures and funding, and also in terms of ensuring that our new leadership can support a change from transactional cultures. How are you assessing your candidates for the CE positions? Are you able to get underneath their formal reference processes? Is there going to be a deep dive into their current work, how they are viewed sort of from beneath rather than just from across and above?
I might tackle that one first, then hoatu ki a koe, Matarori. Excellent question, Sarah. I don't want to go too detailed into the CEO appointment processes, but what I can say is that we actually are down to final interviews and expect and hope to be able to make some announcements about CEOs within the next few weeks, as opposed to interim, who's Martin, who's doing a sterling job with the transition unit. It is key, and we've emphasised this throughout our interviews for CEOs, because that's, as a step down from the board, that's where the culture shift comes from, to emphasise workforce, and the need to have those be relational with the workforce, as opposed to not only the transactional, but result in adversarial relationships with all of our health workforces. We know, it could be under no illusions that there's a challenge. We will always exist in, to a degree, a resource-constrained environment, and there will always be more things that we all want to do as health workers, and the need is always great, and we want to do better for all of our patients. So under no illusions that, we're still going to have prioritisation arguments, or perhaps not arguments, prioritisation discussions as we go forward. But we're also, I think, have the opportunity to introduce some genuine efficiencies in the system, and re-look to make sure that every dollar that gets spent in healthcare, as much of it as possible, gets sent to the front line through frontline health workers and the care they deliver. So alongside all of that, it will also take a look at what is the the quantum of kind of vote health that is needed to fully effect these reforms. So obviously, we're all going to take a keen interest in budget 2022 moving forward as well. Although God knows money doesn't solve all the problems, it probably creates just as many as it solves. So don't want to make overly important promises, but again, I think if we go into this with the right attitude, both as the boards and as the workforces, me mahi ko tahi, all working together, I think we've got the best possible chance of flipping the dial.
I think Curtis summed it up well, but I also just want to add around not only for hospital services, but also for community services and Māori health providers, which have been funded inequitably at times throughout the last decades as well. So definitely the interest, coming back to the budget question, it will be around the boards pushing for multi-year budgets, which I think would be really helpful around how we plan, so that with the New Zealand Health Plan, it's not just in yearly budget cycles, but actually we have more certainty or longer term funding to invest for the long term rather than kind of budget cycle by budget cycle with vote health. So I think that would be something that we'll be pushing for. And secondly, around how we use the funding as well, as Curtis briefly spoke to, around equity, how we won't have 20 different DHPs with 20 different budgets, 20 different ways of allocating some of the funding, but rather having being able to plan more as one system in order to be able to make more effective and efficient funding decisions, particularly based around equity, to be able to look across the whole system rather than just looking at our particular part or our particular DHB area, so that we could use funding more effectively and efficiently as well, would just be what I'd want to add to Curtis's kōrero. Kia ora.
Look, thank you all so much, Martin, David, Mataroria, Curtis. He mihi nui ki a koutou. It is an enormous task that you have taken on. We will be walking alongside you in it, and we will also be holding you to account, as you would expect. We do welcome your priority to support and sustain our existing workforce and to do better around workforce planning as a key driver of our new health system. We've listened really carefully, and of course we do also have a bank of questions we haven't had time to put to you, so we will look at a mechanism by which we can share those with you and continue our conversation. Nō reira, tēnā rā tātou katoa.
Thanks, Sarah. Thank you.
So that brings us to lunch. So we will be back online at 1:30 with a Meka update. Kia ora.